So before you ask yourself, why should you do endoscopy? This is something that you should keep in mind. So most of you probably are, or all of you are doing open surgery. So these are my insights on what is the difference between open surgery and microsurgery. As you can see, philosophy is totally different. And that's why I see transforaminal endoscopy as a major breakthrough and something really new. And that's why I will tell you later on why do I think that transforaminal endoscopy is better than intralaminar endoscopy, even though they're both endoscopies. So when you enter from behind, you always enter in the dorsal epidural space, which is if you use transforaminal endoscopic surgery, you always go or enter the canal in a ventral epidural space. So this is the first major difference. Now you all know that pathology most of the time is in ventral epidural space. That means that you don't have to distract the dura and don't have a possibility to, or you have less possibility to injure the dura, okay? This may not be important in lumbar spine, but this is definitely important in thoracic spine and in cervical spine, which I think you're aware of. So there is no displacement of dura or nerve root if you go from ventral, which you do definitely have to displace the dura and the spinal nerve if you use a dorsal approach to the spinal canal. There is no destruction of posterior elements. This is obviously understood. Think of it in this way, and somebody told me, and I really remember this sentence: why do you want to tear down the roof to enter the house when you can enter the same house through the open door? And this is the main philosophy of me from intralaminar versus transforaminal approach. Okay, so we can argue about less scar tissue. Obviously the scar tissue depends on a technique of the surgeon, but definitely the muscle damage is less if you use endoscopic approach rather than if you use open discectomy. Even though if you use small tubes, sometimes I use 18 millimeters tubes, but still the scar is more pronounced. What is interesting here, and I want to exaggerate that and emphasize it even more during my lecture, patients operated endoscopically are awake. So they are in a local anesthesia and they can report right away if they have any kind of discomfort, pain, and so on. So you get real-time feedback from the patient, which is, I think, important, especially if you work in a private hospital. And this is also a major difference if you operate in general anesthesia versus local anesthesia. Lower rate of infection. This is third most important difference that I emphasize to my patients. So when you operate with microsurgery, you operate in air. So the medium is air. While if you operate in endoscopic surgery, the medium is water. Now this water is not still, this water is running. So you are flushing away all the possible pathogens, and also you're flushing away blood. So that's in that sense, I really never had an infection during surgery or after endoscopic operation. I had several, of course, infections after open surgery, but I never had infection after endoscopic surgery. Okay. And then faster post-operative recovery. Obviously, patients can go home the same day or the day after. It really depends. And they can definitely go back home early and go back to work early compared to open surgery. So this is the first thing that you should remember or think about when you have a decision if you want to go into endoscopy or you're going to stick with microsurgery. The second question that you want to ask yourself, there are several companies providing endoscopic instruments, and Jaap already told you. So you should see the benefit of each company. Now the benefits for Maximor Spine are numerous. Jaap already told you, so I won't be saying much about it, but let me emphasize from the neurosurgeon or from the surgeon perspective. First of all, these patented hand reamers are breakthrough because you can enter the spinal canal at all levels. And I'm not only speaking about lumbar spine, I'm speaking about thoracic spine, I'm speaking about cervical spine. So without significant fear that you're going to harm the neurological structures, okay? So if you are familiar with the instrument, if you know how to do it, then dull tip but sharp instruments are very effective in entering the spinal canal. As you've seen, the instruments are different for various procedures. I use some of them. I don't use all of them, but if you're interested in a specific part of, in specific technique, obviously you have all the instruments. You can, as I told you, enter in a spinal canal in ventral and in dorsal space. You can do joint ablation system, which I really believe in. I used to do radio frequency ablation before, because I'm also acquainted with the pain procedures, but I believe more in success of ablation procedures done under direct eye rather than percutaneously using only radiofrequency probes. Okay. So let me now give you an illustrative case about the transfemoral technique. I always like to show this patient because most of you, when you see the MRI scans, won't believe that this can be done endoscopically, especially not transforaminally. And you know, I want to encourage you to see that this is possible. So we have a young patient, 4 months of right-sided sciatic pain. In last week, prior that he referred to me, he had a foot drop, so decreased of motor strength, a positive straight leg raising test, and L5 and S1 nerve root irritation, and he didn't have any sphincter problems. So obviously, you can see that this guy had a big herniation at L4-5, migrating upwards, okay? So this is why, and you can see it in this picture, this is why L5 nerve root was endangered, even though it is L5-S1, this level. So most of the, you know, when you ask surgeons, this is L5-S1 level, which is the toughest level for endoscopy, especially transforaminal way, which is definitely not true. And then up migrating is also the toughest of the toughest because it's going opposite direction that you are coming in a spinal canal, okay? So take a look at these slides. I'm going to show you the postoperative slides again. This is how I plan my surgery. So you want to be in a med ped line with the tip of your instruments. You want to go just above the iliac crest. So don't think about is it high, is it low, is it wide. Just go above the iliac crest, and then this is the approximate distance from the midline, so let's say 13 centimeters for this particular patient, okay? In a books, you'll see the numbers like 12 centimeters for L5-S1, 10 centimeters for 4-5, and 8 centimeters for 3-4 levels. This is just an rough estimate, but for each patient, even though I did hundreds of them, for each patient, today I still plan my surgery in this way. So if I always ask MRI scans, I always ask ASIAL slides, and this is how I plan. You put your trajectory at the med ped line, and then if you're speaking about L5-S1, just above the iliac crest. If you're addressing L4-5 or 3-4 levels, then you don't care about iliac crest anyway. But then you plan your trajectory to damage as less SAP as possible. Now, when planning this, you can also see how much bone you're going to drill. So even before I start surgery, I know that I'm going to have to drill more bone or less bone with the reamer, okay? So basically, this surgery is obviously done under X-ray control, so you need to know a good bone anatomy, and obviously you need to see the difference between these two AP views. So this is the true AP view, and this is angled AP view. What's the difference? Can somebody tell me? Do you see the difference?
The lines, and you have to have a very nice sharp line of the vertebral end.
Exactly. So this is squared. You want to have a squared end plates. So the end plate is line like here, and in here you see that the end plate is oval. Okay, so in this case I know the X-ray is just right like this, and this is angled, so it's like this. Okay, you always start in this. When you do transforamen endoscopy, you always use this angle. When you do interlaminar endoscopy, you can do it this way. This is understood. Okay. So I mark the midline, okay, I'm squared end plates, and then you see I always plan my trajectory just above the iliac crest. So this is the iliac crest, okay, just above the iliac crest. I don't care if it's high, if it's low, just above the iliac crest. We introduced now spinal needle inside, okay, and I give contrast. Why do I give contrast? Because I want to see where my disc herniation is even before I introduce the scope. This is first thing. Second thing is I want to see, when I take out the disc herniation, I want to see the clearance of the contrast. And when I apply contrast, I also give several drops of blue dye. So I'll show you in a video. This is how you can easily distinguish what is disc, what is not disc. For first time surgery, this is maybe not so important, but if you have revision surgery, then it's really important to distinguish what is the scar tissue and what is the disc tissue, okay? So in here, you can already see, I don't know if you can see it because of the lights, but you can see the delineation of the disc herniation even before you enter with the scope, even before you see it with your own eyes, okay? So this is important, especially for the beginners. You see how we have up migrating disc herniation, and you see how it goes. So this is up, this is the disc level, of course, and this is up migrating. You see the yellow arrows. So this is how I delineate disc herniation even before I introduce the scope, okay? So then we introduce muscle dilatator over the kitchen wire, and these are the reamers I was talking to you about. So this is number 4. And then sequentially you can have 5, 6, 7, 8, 9. Just recently they have 5.6 and 6.7 reamers in order to skip, so you can ream the same amount of bone in, with the fewer instruments and with less time. So if I have really stenotic foramen, I always start with number 4, which is first reamer. But if I have a higher foramen, then I skip, maybe first reamer is 5.6, and then I use only 6.7 and 8. So 3 reamers instead of 5 reamers, okay? But this is not so important. This is number 8. So when you see this position of reamer, you see how it's already almost in the middle of the spinal canal. So you would think that I injured the dura, or that I'm deep in the disc, which is obviously not the case, because if you see lateral view, you see that I'm not even in the disc, and I don't want to be in the disc. Now we can discuss, there are 2 techniques, inside-out technique and outside-in technique. Obviously this is outside-in technique, which I am most prone to. I never, if I don't have to, which most of the time I don't, I never go into the disc, because there is no need to go into the disc, okay? So most of the time, or all the time, I try to stay out of the disc, or at least enter the only the dorsal portion of the disc, so the small portion, not to make a bigger hole than it's already made in the disc, okay? I want to be as less invasive as possible. After that, we introduce a scope and different instruments for grasping the disc. Now you see, when I take the disc out, there is no more contrast here, okay? So if you now compare this picture with the previous one, when we did have a contrast, this is also a proof that I've taken everything completely, the disc herniation out, okay? So this is how it looks like in a real patient. So you see, this is the disc, this is also the disc, but this is sequestered. So the sequester didn't stain, okay, because it's away from the disc, okay. Now with gentle movements, sometimes it comes in one piece, but sometimes it comes in a piecemeal fashion. This is medial, so 12 o'clock medial, lateral, this is cranial, this is caudal, okay. You see now the color of the disc is really bluish, and you can easily distinguish it from all other structures.
So you are using the dye routinely?
Yes.
In each case?
Yeah, in every case. In disc surgery, if I'm doing stenosis surgeries, then I don't need dye because I don't need disc anyway. But oh, it's just a couple of drops, maybe 4 or 5 drops in 2 milliliters of Omnipac contrast. Yeah. So I usually sometimes get questions. Does the size of disc herniation matters? Because people are asking me, if you have such a big herniation, how can you pull it out through the small tube? But it doesn't matter. I never had a disc herniation so big that I couldn't bring it out from the working channel. Yeah. Obviously, when you take the disc herniation out, then the bleeding starts because you decompressed it. And this was also the case. And when you take the herniation out, you'll see the pulsation of the dura, of the nerve. And that is third also sign that you really decompressed enough, okay? So now if you see, this is the level of the disc. This is the posterior part of L5 vertebra, okay? So I didn't even enter the disc. I only took out the sequester that was going cranial, okay? And when I show you now these pictures, so these are now post-operative slides, okay? So if I show you this slide or this slide, you will never guess that the patient underwent surgery, okay? But if you take a closer look, then you can see the difference between this triangle here and this triangle here, okay? So this is how we know that I rimmed only a small portion of the superior articular process, SAP, okay? And this is post-operative MRI. So the guy, this was the husband of my scrub nurse that I work with. So they flew in from Ireland on Tuesday, and they flew back in Ireland on Thursday, I think. So they stayed maybe 2 days in Croatia and went back home. So with plane after this kind of surgery, okay? So this is, yeah. Now let me give you some tips for learning curve and maybe to encourage you to use endoscopy a little more. So if I need to say what is the most important thing, then I would say pre-surgical planning, okay? Definitely spend your time as much as necessary to prepare for the surgery. Look at the size of the disc herniation, the position of the disc herniation. Don't look about iliac crest, rather look about the facet joints, because facet joint is going to tell you, first of all, how much you're going to have to rim the facet joint, and the position of the facet joints are going to tell you if there's going to be maybe post-operative instability, look of the height of the disc, look of the modic changes if you have them. So these are all the things that you need to take into account before going to surgery. This is just for the educational purposes. I don't mark all these things on the patients anymore. But again, midline, this is the disc line, this is the iliac crest, this is trajectory. So 12 centimeters, 13 centimeters, sometimes it's even 10 centimeters. If the person is 10, then I use 10 centimeters. Sometimes I use 8 centimeters for the L5S1 level, okay? So it's not always 12, so first tip is to analyze the disc herniation and anatomical structures. Don't worry about iliac crest, worry more about facet joints. Other tip is you need to study in detail spinal anatomy. If you have good C-arm, so X-ray, you obviously have better pictures. It should be digital in our times. But then again, if you have disc surgery, most of the bones are normal and good. But if you have older patients, if you have osteoporotic patients, then these images won't be as nice. So you still need to know exactly where you are and where you want to go. This is also, so the second tip is to, you know your anatomy, and you always want to be in true AP and true lateral. How do you know that you're in true lateral? This is perfect example of true lateral. You see only one pedicle, even though you know there are two pedicles. So the pedicles overlap, okay? If the pedicles do not overlap, this is not a true lateral and you're off the line, okay? So this is the second tip. Initial problems are when you start performing endoscopic surgery by your own, the needle placement, okay? So since I'm doing this in a wake patient, the local anesthesia, you need to anesthetize the skin first, then the fascia. Muscle is not painful, fascia is painful, and then the bone is painful, the periosteum is painful. So you give enough local anesthetic around the bone. You can easily give contrast in foramen also for patients. This is especially important if you have foraminal disc herniation when the exiting nerve root is compressed, not the transversing nerve root, okay? So anesthetize facet joints, infiltrate the annulus of the and put some anesthetic into the disc. This will make procedure more comfortable for the patient. Okay. You need to get acquainted with your instruments. This is done very easily, or I can help you today, and people that you provide instruments from will help you with that. And then once you've go into more and more deeper endoscopic surgery, you'll need to know the difference between the neurological structures. Now I'm going to give you examples. So you see, without staining, this was without staining. So this is the soft tissue. So we know that this upwards is neurological structure, but this here is also soft tissue. So it looks like a disc. Okay, so I think this was the nerve. I shielded it I protected it with a working sleeve, and now I thought that that this is disc. Okay, so I thought that this was disc herniation. So I tried. I mean, I'm speaking first like I did, but this is not my case. So you see this? You've seen this? Yeah. So this is what happens if you didn't recognize structures right on time. Yeah, and this is this patient was operated before I came to the Axis Hospital in general anesthesia. After this, all patients are operated in local anesthesia, because this would never happen if patient was operated in local anesthesia. Okay. So a local anesthesia. The tip is also to take your time to record and watch your own surgeries, because when you are in the surgery, your mind is thinking differently. But after surgery, when you already know what you've done, and then when you watch surgery for a second time, you get a different perspective, okay? You can have different problems with visualization. Sometimes the problem is a bleeding, okay? So I also want to show this little movie. You need to think about anatomical variations, and you need to use indigo carmine. You see how now we always have a bluish tissue here. So this is a revision surgery, I think. Yeah. There is a scar tissue, and you will see now also if you're too aggressive, then you can have you can have a dural tear. So there is no problem of nerve injury, but when you have revision surgery, and if you didn't distinguish good the dura from the scar tissue, you can have dural tear. And this is obviously evident that this is dural tear. Responsive patient in local anesthesia, we already discussed this, so thank you for your